Today on the New England History of Medicine Society Spoken History Project, we are honored once again to welcome a member of the Herrick family. Today we have the pleasure of sitting down with Beth Herrick, who is a radiation oncologist, and we look forward to learning from her experience training and practicing in the field and getting an understanding of the changes the field has gone through and any technological advances and advances to the care for patients that have been made. So, first of all, Dr. Herrick would just like to thank you for your time and welcome you, and excited to speak with you today.
Great. Thank you. Me too.
Yeah. All right. So I took a look at your CV, and it seems that you have been a Northeast practicing lifer for the most part. And so,
Yes.
yes, you did your medical training at Cornell in New York. And I just want to start with asking, number one, were you from New York originally, or did you move to Cornell for medical school specifically?
Yeah, no, I grew up in Pittsburgh actually, but ended up going to Cornell undergrad and oops, I'm leaning forward again. And that was a function of not just academics. Actually, at the time I went there for sports, to be honest with you. But luckily it was a good choice because they have their own medical school. So yeah, I actually was a gymnast at Cornell for four
Oh,
years.
wow. What was your event or your particular
I was
skill?
an all around. I did all events, and my best event was the uneven bars. So I did a lot of traveling with that and made lifelong friends. It was really a wonderful, it was the best part of my college experience, frankly, because pre-med at Cornell was very cutthroat, as you might imagine, as it is most places. And not a lot of good mentoring, big school. Um, and I think I could have gotten lost in the crowd there had I not had a smaller niche. So athletics was not only, physically healthy for me, but also it gave me a niche. And ultimately, I think people recognized as I was accepted to medical school that the discipline that it requires and also maintaining your grades while still juggling, you know, probably 20 hours of work week of exercise, 20 hours a week of athletics and then traveling on the weekend. I mean, there was a lot of studying for exams in the back of, vans and that kind of thing. Uh, but yeah, I always have believed in sound mind, sound body, and I think the two complement one another and really work hand in hand. And I think as a physician, not enough of us take good enough care of ourselves, both physically as well as emotionally. I mean, there's been a push towards, self-care, although honestly, I don't see any changes in the system that really allow for that anywhere. But we can come back to that. But anyway, I went to Cornell undergrad, had a great experience there, got into Cornell Medical School, was thrilled about that. So that's why I moved to New York. And that's where I met Tim. Tim was a medical resident 3 years ahead of me. I had a great experience at Cornell Medical School, really loved living in Manhattan. That was a lot of fun. And pretty small med school class, about 100 people. At that time, a third of us were women, so the number of women were rising. That was in 1982 to 86. The following year, they accepted 50% women, and now I think it might be a higher percentage of women, but I was
I
just,
think, I think, yeah, as of recently, at least US-wide, the number of matriculants who are female is higher than that are male when they
yes.
use like a binary male-female statistical method. Yeah.
Right,
Yeah.
right. But I was just at the tail end of it being a very male-dominated uh, field, so that the attendings were still kind of male-dominated. Those demographics, as you know, have changed over the years.
Yeah.
And I think to a certain extent that impacted my experience in my career, for better or for worse. And also, uh, well, I'll just leave it at that.
Yeah,
But
well, actually, if I may ask, I wanted to just kind of back up, and we'll circle back to your time in medical school briefly. But I wanted to ask, what were you studying at Cornell as an undergraduate, and how did you choose that particular field of study? And yeah, did you know you wanted to go to medical school while you were an
I,
undergraduate?
yes, I went to college, believing I wanted to go to medical school. So I sort of did what I thought you were supposed to do, a science major. I was a biology major for 2 years, and then Cornell has five or seven colleges within the institution. Three or four of them are land grant state schools, New York State schools. The cost is a lot less, so I switched from the arts school, which was private, into the state school, which was public. And even though I was an out-of-stater, it was significantly less money for me. So because there was a point at which I also had to juggle financial aid. I worked 20 hours a week for 2 years in addition to the time I spent doing gymnastics.
And may I ask, what was the side job you had, the 20 hours a week?
It was very easy. I started in the cafeteria and I did not like slopping food on people's plates with a net on my head. I felt it was kind of demeaning. But more than that, you had to clean up afterwards, and I had to lift chairs and tables, and I was exhausted. I had just come from workout. So I lasted a week, and then I worked in the graduate student library. And it was mindless, frankly. It was filing uh, congressional bills, actually. It's kind of interesting, but it was easy. The people were lovely. I could come and go when I had my own time. So it really helped my lifestyle. And then my sophomore year, I was granted a scholarship um, by it was an athletic slash academic scholarship, and they don't really give many uh, scholarships at Ivy League schools. They don't give athletic scholarships. But this was an endowed scholarship, and the three criteria were that you had to live in Pittsburgh, so it was a wealthy woman in Pittsburgh. You couldn't be married. You had to be an athlete, varsity athlete, and you had to attain three, like a 3.2 grade point average. So fortunately, someone who had it before me flunked out. Not fortunate for him, but fortunate for me. And the football coach recommended me for it. So a lot of the athletes, that's what I say about the athletic community. It was really a niche for me, not just the gymnasts, but I knew the wrestlers and the football players and lacrosse players and the coaches. And frankly, it made it a lot more fun and it gave me another outlet other than just the intensity of studying science all the time.
It
Uh,
makes sense. Yeah, I think a lot of people who go into medicine have some history of athletics. It's not
yeah,
uncommon to find that. And
yes,
I think to your point about being able to juggle multiple competing commitments and really kind of push yourselves in physical and mental ways, I think that's kind of all part of medical training in some regard.
I agree. I agree. But having procured that scholarship, I was able to drop my 20-hour a week work study job. So that was a big relief and that helped. So, I know I'm not alone and lots of kids. I had six siblings. We had my dad, mom and dad had, when I was in med school, two of my siblings were in college, and
Mhm.
um I think maybe another was in no. So I was in med school, two of my siblings were in college, and my dad was laid off in his mid-50s. So, finances were a real consideration. And
Are you the first doctor in your family from
I
like your
am,
parents' side?
I
Okay.
am not the first. My father was very educated.
Mhm.
He had a MBA. My mother was not educated. She, very bright woman, very well informed and well read, definitely a sharp cookie. Probably the brains of the family. But she dropped out of school in seventh grade. It was during the Depression, and her father had TB and was in a sanitarium, and she had to support her family. So, and then she was a homemaker for 60 years.
How
But
did your parents, I'm sorry to interrupt, but I'm just curious, how did your parents receive your interest in medical school and were they supportive?
they were totally supportive. They were wonderful. I mean, my parents were the best ever. They pretty much supported almost any and everything we wanted to do. Some things that didn't really make sense, like a purebred dog that, anyway, So, but if we expressed an interest, they would pretty much try to make it happen. And they saw that I had historically done very well in, you know, all through all through school. And I and early on they had said to me, I think you'd make a good surgeon, because I used to take apart like our vacuum cleaner and I don't do this at all anymore. My husband's probably listening saying, well, that doesn't sound like you, but I would,
He's going to learn some things about you when he hears this
yeah, I
interview.
used to like take apart our vacuum cleaner and pull out all the fuzz and with little tweezers, and they said, you're going to be a neurosurgeon. So but no, always very, very supportive. And just assumed that they would make it work financially. Never influenced me in terms of, you need to go to a less expensive school or anything like that. So, and they were really expert money managers, as many people were of that generation who lived through the Depression. But they put us all through college and a couple of us through graduate school. And
Do you remember how much your college and medical school tuition were at the time?
not exactly. I remember, though, my debt at the end was only $50,000, which is so different than
Yeah.
now I do remember my scholarship was $7,500, and that was a big deal. Um, do I know what I'm thinking, like maybe in the high 20s for my undergrad, and maybe something similar for med school, something
That's
nowhere
per year.
per year.
Okay. Yeah.
So, but
So
I
we're
don't
talking
hold,
$20,000 per year, and your
yeah.
degrees were each 4 years.
Right,
So
right.
yeah.
Yeah.
Mhm.
But so I had a lot of financial aid. That I think it was 40 before I finished paying off, even though it wasn't it was a minuscule debt relative to, these days. But and honestly, I never really thought about, well, that's not true. I was gonna say I didn't think about money. That's not true. I did. Because yeah, I was very frugal. And yes, I almost had to transfer when my father lost his job, but then I was able to get that scholarship and switch into the less expensive school where I had to switch my major to microbiology. Um,
So you went from biology to microbiology, is that correct? Okay.
mhm,
All
mhm,
right. And then So you finalized your time in undergrad with a bachelor's of science in microbiology. Is that correct? Okay.
Correct.
And
Yeah.
then whenever you went to medical school, what were you studying? What were the classes you were taking? And how did you find your passion in radiation oncology?
So I went to I went to medical school thinking that I wanted to go be an orthopedic surgeon because I always had this notion that I wanted to be a surgeon, and that was really all my exposure. I had shadowed the sports medicine doc at Cornell and worked in his clinic for a little bit. So I thought that that's what I would do, but I didn't elect. So the first 2 years, you're pretty much repeating everything you do undergrad, as biochem, physics, um, with some, physical diagnosis and other more relevant classes thrown in, but you repeat a lot of the sciences that you've done ad nauseum. Um, but on my third and fourth year, when you can choose your electives, I did a rotation in orthopedic surgery, and I found it boring as hell, to be honest with you. It really, it's not that intellectually interesting or challenging is what I thought. And it's also very physically demanding. And I had a female orthopedic surgeon, um, let's see, mentor, what do they call her? Advisee. Um, but there were two procedures that I saw as a resident or as a student where I said, I am not doing this. And one was somebody in traction in bed, and I had with a pin through his tibia, and I had to unscrew the tibia, and there was no anesthesia, and the guy was in horrible pain. And it was physically hard to do. And then the second was in the ER, I like a 5 or 6 year old who came in with a green stick fracture, which is not completely through the cortex. So you have to exaggerate the deformity. And so they did this and that, and he was screaming bloody murder. And I decided this is boring and I do not want to inflict pain on people. So I ended up still thinking I wanted to do something in with a surgical side to it. And I loved my OBGYN rotation. And as it often is the case, sometimes it's who you meet. So the intern that I worked with was this very dynamic young woman, great teacher, full of energy, loved what she did. We really hit it off. And I thought, well, this is an interesting specialty because there's some surgery, there's some medicine, there's, you get to operate, there's some oncology. But what I ended up ultimately liking in medicine was not what I thought that I would. Um, I ended up finding that although I love procedures, I like the intellectual part of it so much more. Although I do like using my hands, I like the intellectual diagnostician part of it. So I actually, at the end, when I was applying to residency, I was trying to decide between pathology and OBGYN, which couldn't be more different. I decided I wanted to see patients, so I did OBGYN. I did a year of OBGYN, and I was very unhappy. I loved the GYN part of it, and again, that really surprised me. Not surprised me. I didn't like the OB very much. Again, I found it kind of boring and not intellectually challenging. The part of OB that I liked was the medicine, like preeclampsia, hypertension, those things fascinated me. Um, the rest of OB, I would I hope OBGYN obstetricians aren't offended by this, but I would always say when I said I found it was gratifying, but
We'll say different strokes for different folks.
yeah, I would always say it's
Yeah.
kind of you're up, you're down, you're in, you're out. The
Yeah.
baby, I didn't find that intellectually. You spend a lot
Mhm.
of time waiting, you know. So I was much more fascinated by the oncology. That's when I really started um, kind of change. And I was unhappy in that it was the mid 80s. I was in Washington, D.C., and it was peak malpractice. OBGYNs were getting sued right and left. And I would sit in the on-call room with the attendings while they were waiting for their patients to dilate. And they essentially would said to me, save yourself while you still can. This is a terrible lifestyle. And it's very litigious.
So
So,
so do you think the litigious nature at the time of the practice, do you think it came from a valid place where, the policies and practices in obstetrics were not, optimal for outcomes for the patients? Or do you think they just saw like this is, someone to sue, something went wrong, despite their best efforts, I'm going to sue them anyways?
I actually think it was a little more of the latter than the former. I don't know how much of that was training in Washington, D.C., where there were, you know, uh, per capita, a lot of lawyers. I think with OB, it's very obvious, a bad outcome is tragic, and you have the life of the mother and the baby that you have to protect. Pregnancy is a much more dangerous state than most people understand, and even though women are young and healthy, there's, obstetric complications are awful with often tragic endings. So, and I think the statute of limitations was 21, so you could, say your child had autism or, problems when they were in their teens or something, you could, you know, harken that back to birth trauma or something, maybe without a tremendous amount of data. I was, it was implied that, and I wasn't seeing poorly delivered medicine. It was implied that it was just because it's so emotionally charged with, the health of your child, that a lot of it, well, I think surgical specialties in general, the rates of lawsuits are probably quite a bit higher. But so between the lifestyle and me actually just not half of it, it didn't really turn me on intellectually. And I knew that I wanted to have my own children, but that's when I was exposed to oncology. Um,
Or through the gynecology aspect,
yes,
like gynecologic oncology. Okay.
yes. So ovarian cancer, cervical cancer, vulvar
Mhm.
cancer, all the
So,
GY.
so, so, so as an intern, were you doing rotations and going to the OR
Yes,
to see these conditions?
yes,
Okay, I
yes.
see.
And
And
we
that's what
did,
got you into that.
yes,
Mhm.
exactly. And we did brachytherapy cases in the OR, for cervical cancer primarily.
Mhm. And
Uh,
for those who may not be familiar, just because we may have some non-medical people see this, can you explain what brachytherapy is?
yes, brachytherapy. So most conventional radiation therapy is what we refer to as external beam radiation, where we use primarily photons, which are X-ray beams delivered at a distance to the patient's tumor, what you've defined as the target area. And the
And you
patient,
see that on cross-sectional imaging, is that correct?
yes, now you
Mhm.
do. When
Yeah,
I originally trained, did not, but we can talk about that. But
we should, absolutely. Yeah.
yeah, so but the X-ray beam, again, it's a photon and it never touches the machine never touches the patient, and the beam traverses normal healthy tissue to get to its target. So hence the side effect profile associated with it, the injury it causes to normal cells. With brachytherapy, it's a way of utilizing radiation and actually placing the radiation source, physical source, like radium or iridium or cobalt or actually physically within a cavity or physically touching the tumor tissue. And it allows, and the dose is, so it's a physical, it's actually, a little piece of radium. The stuff that Madame Curie carried around in her pocket and got cancer from. But cesium. So there are different isotopes with different half-lives, but it's a way to sort of bring the radiation to the tumor without having to traverse all the normal tissue. And certain malignancies lend themselves better to that than others. Ones where you actually have a cavity that you can insert so you could put radiation seeds within the uterus, within the cervix, within the vagina. In men, we now do radioactive iodine for prostate cancer, where seeds, little pellets, are actually placed in the prostate, and it delivers the dose from the inside out. So the source actually delivers the dose, and then it falls off fairly quickly, so that the normal tissues are getting much less dose. So it's a way to dose escalate, increase the dose to the tumor, and try to minimize some of the risks and side effects.
Well,
Uh,
when you were doing your training, so after you did 1 year of obstetrics and gynecology, that was your internship, then it seems like you moved into internal medicine for a 3 year residency process. And I want to ask about which conditions were being treated with radiation therapy at the time. And then also, to get into internal medicine, did you have to go through a match process to transition out of OBGYN, or how did you get into internal medicine?
Not really. So the reason my intention actually wasn't to switch into internal medicine, but Tim and I were married at the time and kind of trying to finish our residencies together and move out of Washington together. And it would have taken me a couple of years to get into the radiation oncology program there. Medicine honestly was a default, a placeholder. But, and I guess there were a fair number. I was at GW and we figured I'd finish medicine the same time he was finishing his pulmonary fellowship. And then if I still wanted to, I could do radiation oncology at that point. But it was a long slog. um, It was, I don't remember it being hard to get into the program because they knew me and then they knew the work that I did. And I think there were a fair number of interns that left the program. So I very easily, with my CV and my record, slid right into and I actually liked it. The other thing about OBGYN is I actually didn't really like the people that I was, not all of them, but it's a surgical subspecialty. It's very sort of macho cutthroat. And residents weren't treated very well. And I guess it attracts a certain kind of person, of which I was not.
Do you
Um,
think some of those things were better when you moved into internal medicine in terms of the
yes,
kind of cutthroat
yes,
aspect? Were they
yes.
treated better?
They had we still worked like dogs, but there was a lot more humor, a lot more collegiality. I felt like, oh, these people are more like me.
How many hours a week were you working at the time between OBGYN and your internal medicine time?
Ugh. Um, Oh, it
You can
was
just ballpark like more than 60 hours a
well,
week,
it
more
was probably
than
more than 80, I would think. It
Mhm.
was like OBGYN, we were often on call every other night. And I think as Tim explained, that meant so we started at 5:30 in the 5 or 5:30 in the morning because some of the OR cases you had to round on your patients before the OR. So your day might go from 5:30 if you were on call, all day, all night, up most of the night, all day the next day till about 5 o'clock. And you did that every other night. So that was in excess of 100 hours a week, I'm sure. And I also found out that I don't do very well with sleep deprivation. I really didn't tolerate it well. Um, but so there was the same amount of sleep deprivation. I would say the on-call schedule was a little bit better. In medicine, there were more medical residents. There were only 9 residents in my internship year. And that was a big OB/GYN program. But so the lifestyle was a little bit better, not much, but I liked the people a lot more. And I liked the intellectual, again, it surprised me how much um, I loved medicine. And I still love medicine. And I still feel that, the term that we would use for people who are more inclined to go into medicine, I actually am more of a flea. I don't know if you use that term
I've
anymore.
never heard that. What is that? Yeah. What
Yeah,
does
a
that mean?
flea meant that you were sort of a medical geek. And I forget what they might have called surgeons like blades or something. I don't remember. My husband.
Blades and fleas. I see.
Yeah,
Okay.
I don't hold me on
Yeah.
the blade, but a flea
Yeah.
was someone who was like, again, kind of more like the diagnostic end and got off on the differential diagnoses and diagnostic, connecting all the dots as opposed to taking a saw and, you know, cutting through someone's femur.
I
There was
see. Okay.
a little bit of uh like the surgeons would kind of a little bit of condescension in those terms, like the fleas were kind of geeky and the surgeons were not that smart. It was
I
kind
see.
of
Okay.
kind of the
Yeah.
implication.
I
But
understand. I understand. And during
yeah,
your time, oh, sorry, go ahead.
mostly tongue in cheek, but
Yes.
you know,
All in good jest. That's good.
yes, yes.
And so whenever you were doing your internal medicine training, did you get some time to observe some oncology
Yes.
work? Okay. And what
Yes.
kinds of things were you seeing? And how did
Yeah,
radiation come into the treatment at the time? And which different organ systems were being treated
yes.
with radiation?
So it was primarily the GYN organ systems. Again, uterine, vaginal, cervical, some head and neck brachy, and uh, also prostate brachy. The seeds in the prostate that was just being developed when I was training. The other thing about my internal medicine training, and this, I know Tim spoke a lot of this. It was the mid 80s during the AIDS epidemic.
Mm,
So that's why the lifestyle really wasn't better because we were taking care of very sick patients. If you got called, we would always say, if you got a call about an AIDS patient, you knew it was always going to be something bad and something real. That you couldn't just, a headache, give a little Tylenol. Now you had to do an LP, blood cultures, etc. And you were doing them yourself, physically, often by yourself. No ultrasound guidance, just middle of the night. Um, but but yes, I took as many so it was during my time in the OR for the GYN procedures that I met a radiation oncologist, a resident, whose last name happened to be Merrick, Greg Merrick, and we hit it off. We hit it off and just used to laugh and, have fun when we could. And he's the one who said you should go into radiation oncology. If you like oncology, you should go into radiation oncology. And he said the lifestyle is much better than medical oncology. You're taking care of the same cancers for the most part, but with much better lifestyle. And you know what? It was good advice, actually, very good advice, because you're taking care of the same patients with the exception of leukemias. Um, but you have, usually more time with patients, better on-call schedules, much more time. It was much more conducive to being able to be a very conscientious mother and a very conscientious physician and still try to take care of myself. Whereas medical oncology is, well, medicine and medical oncology, the lifestyle isn't great still. But yeah, but I did as many rotations as I could in like I did a leukemia and lymphoma, a sarcoma rotation, lung cancer rotation. And I was very fascinated. It just floated my boat. I don't know why. I found it very interesting. Even just learning the staging, I was really good at staging and it just clicked for me. And so
And
after
can I ask, was it atypical for females to go into radiation oncology,
it
or what
was
was the
it
climate
was
like
more
for?
heavily weighted, yes. And some of the training programs earlier, 10, 20 years earlier, were actually you trained in you were admitted to a radiology program and part of your training would be radiation oncology and part of it would be radiology. That was before my time. But yes, it was still heavily weighted towards men, but that was changing. Um, in my residency, there were, so then after, but so as I was doing internal medicine, I still always kind of in the back of my mind felt like if I have the opportunity, I'd really, really like to do a radiation oncology fellowships it was a residency. So yeah, I have a very broad background, a year of OB, um, 3 of medicine, and then uh, 3 of radiation oncology. But I have always said that I feel that all my training has served me in really good stead, made me a better physician, made me a really atypical radiation oncologist in that radiation oncologists tend to be very like all about, there's a lot of physics and just sort of all about the technology. And honestly, I don't think, although they're excellent at what they do, not a lot of them are good all around physicians.
Well,
That's
I see
what
that as
we're
kind of a,
required to be, but I prided
yeah,
myself in being able
yeah.
to be a more, it made me a better doctor, made me a better doctor.
Well, I think the idea of kind of seeing the bigger patient in general is actually, I think, increasingly rare because there is so much push to just kind of hyper specialize and hyper focus. And, even within radiation now, there's so many different subspecialties, especially if you go to a big cancer center, there's people who only do head and neck, people who only do
Yes,
gastrointestinal and things like
yes,
that. And so, I think that's
absolutely.
just a general trend. Yeah.
Yeah, I think it's a general trend for sure. Sadly, I think I understand the importance of it, but I think some things are being lost too with the hyper specialization. And one of my pet peeves is, and also with the computers, to be honest with you, when you're sitting in a room with the patient, having to fill out your, epic algorithm, make sure you hit all your you know, benchmark, stuff that your bonus is being decided upon or whatever, Um,
Well, to that point, when did the electronic health record, at what point in your career or training did that enter your practice as
yeah.
like a standard?
So definitely not during my internship or residencies, any of them, or my early practice. So it was, I guess, in the like when I came to the Cape, so maybe mid 2000s, that's like 2005 or something like that. I might, yeah, maybe a little earlier, but it was 2000 plus,
Mhm.
maybe
And
two.
would you say, I know, I understand it's like the kind of tedium and kind of distraction of having to, kind of take care of the computer as well as take care of the patient when they're in front of you. Do you feel like, despite that, do you feel like it overall helped with organization and record keeping, or do you think it was a net negative?
I think it wasn't, I think there are definitely things, very positive things that have come out of it, and including, probably the most important thing is data mining. You now have a whole bunch of data points that you can collate and, you know, pull from and um, so I think it facilitates research. Certainly, you get a lot of metrics for better or worse out of it. I think it helps with communication from one medical facility to another. I think that's continuing to get better. As you probably know, that's not been a smooth transition at all. But you're now more able to share medical records between medical facilities, which I think is key. Um, and a lot of handwritten records you couldn't read. So
Yeah.
I think just that simple. But I know in some ways it's been the bane of physicians' existence. But there are definitely a lot of positives too. I do think one of the things with radiation oncology is we're allotted, for the most part, all the jobs that I was in, more time than certainly primary care. I would have a full hour for a new patient and a full half hour for a follow-up, which is unheard of
That's
in some.
fantastic. Yeah.
Yeah. So it really allowed you the time to get to know your patient. So I never sat with I had a computer in the room. I never entered stuff in the computer as I was all
Mhm.
one-on-one with that patient.
And then on the back end, after they had finished the appointment, then you would document everything. I
Yes.
see.
And now
And how you
it
would
wasn't as efficient for me, but I thought it was incredibly important. And patients would verbalize that. I go to my other doctors and they're not even looking at me.
yeah.
Um, and I think that absolutely affects the doctor-patient relationship and absolutely affects how cared for patients feel and how much trust they put in their physician and how much empathy is shown.
Mhm.
So, but I had the luxury of time to be, I mean, it was my style anyway. I would have taken the time regardless, but so critical in medicine, I think, to,
Yeah.
that's the art of medicine. And a lot of the technology I feel is we're losing some of the art. And some of that is just patient communication. Um, End of life discussions is a big deal in oncology. I feel that we as a specialty, particularly radiation oncology, we're terrible at it. We pass the buck. We let somebody else do it. We're not very good at it. We don't want to take the time.
Oh, sorry. So who often ends up getting the buck passed to? Is it medical
Medical
oncology?
oncology, and they're also not
Okay.
very good at it. They do it way too
Yeah.
late, and it's hard. It's hard. Patients
Yeah.
don't want to hear it. Families
Mhm.
don't want to hear it. It's emotionally hard for you. You've got a lot of adrenaline flowing as you're trying to have that conversation. But I prided myself in, and it takes courage. It takes time and it takes courage. And I think a lot of docs don't want to take the time or don't want to be confrontation. It's hard, it's sad, you get pushback. But I think it's incredibly important. And I think it's a disservice when you don't do it for the patients. There are ways to do it and ways not to do it. And that's part of the art. I think you learn how to choose your words very, very carefully. And you can deliver very, very sad news, but you can do it truthfully and as compassionately as you can. But I think it's learned, and I got a lot better at it over time. But there aren't enough doctors doing it. Patients are dying in the ICU when they should be on hospice. It drives up the cost of health care. It's not good for patients. It's not good for families. So I feel strongly about that. The other thing I
I can tell.
the other thing that we've lost, it's much easier to give patient good news and kind of string them along and kind of pretend that, you know, everything's going to be okay, but clearly that's not the case, you know, all the time. Sometimes yes, and I don't mean to say I was like the Grim Reaper. Obviously, you want to try to promote hope and and feel that that family needs to and that patient needs to know that you're going to be with them every step of the way. um but that involves being truthful, I think, too.
Sounds like, you should be nice, but you should also be truthful.
Yes,
Yeah.
yes, yeah.
And so, just going along the lines of the electronic health record and kind of how that changed your kind of practice, have you adopted the voice recognition tools to
Yes,
dictate your
yes, I use,
encounters? Okay.
yes, yep, and I've used several different medical records. Yes, and I've used voice recognition, and that's
Mhm.
certainly helped with efficiency. Uh,
Mhm.
I actually was lucky enough for a long time to have the old fashioned, I'd dictate into the phone and
Oh, wow. Okay.
person would actually, when I
Yeah.
was at UMass, a person would actually type it for me, and then I would get it in my inbox and I would edit it. Um, it would certainly, I retired before we were using AI to generate notes. So, and a lot of people template their notes. I could have done that more. But I was a little spoiled with just talking into the phone. I could just document everything I needed to document.
Would you find the transcription that the typist was creating to be pretty accurate, or would you have to do a
Yeah,
lot of work to get it
no,
into
because
shape?
just like voice recognition, they kind of get to know the jargon and
Mm.
it was pretty good. The stuff they got wrong were the like prepositions and stuff like that, not the medical terms most of the time. Yeah, so and they got to know you and your style, so it was pretty good. But I have another rant, and then I'll stop ranting. But
No, no, please. By all means.
Talk about all the positive ways I think that
Yeah,
radiation oncology has changed.
yeah.
I think along with technology and the very, most physicians work for large hospital systems now, so you are dictated, you're being judged on how many patients a day you see, and you're being told how much time you can spend with those patients. And so,
Yeah, so like you got, 30 for a follow-up. I think it's important for people to know like the standard for primary care is probably 15,
yes.
that's kind of what it's around. So,
Yeah,
yeah.
yeah. And people would say, oh, well, it's cancer. It's so much more complicated. It really isn't, in that what I would always say is, it's very focused. Whereas if primary care, you can talk to them about your belly pain, your depression, your, erectile dysfunction, your rash, your
Sometimes all of it in
in
one
one
visit is
visit,
what the patient
in
wants,
one 15-minute
ideally.
visit. Whereas
Yeah.
people got off topic, I could say, oh, well, you need to talk to your primary care about that. So I recognize that the rapport that I was able to build with patients was in part, I had the luxury of time. And thank goodness I would have a really hard time. And so I think that's one of the negatives, that we really just don't have enough time with patients. But the other thing, I think, to cut corners, um, I don't think we're doing enough physical exams and careful. I think the art of the physical exam is being lost. I think certainly in oncology, there are a lot of physical findings, and you can learn a lot from a physical exam that you're not going to learn, that you even CT or MRI imaging or lab work isn't going to show, so you can learn a lot from a physical exam. And the second thing is, I very strongly believe that this is a healing component to laying on of the hands, that patients feel more cared for, and that physical touch, and I don't mean that in a creepy way, but there's something caring, compassionate, healing about that. And I think we're losing that. And you will hear patients say, my doctor never even examined me. Uh,
Mhm.
some of that's driven by reimbursement. They'll only pay for one breast exam a year. They'll only pay for XYZ. And I think to rely solely on technology, we have to avoid, I say we as a profession have to avoid the temptation to do that, because I think there's still the very human side of medicine that needs,
So,
yeah.
sorry, I was going to ask, was the physical exam heavily emphasized during your training, or were you starting to see that the CT scanner was becoming the physical exam machine?
I think radiation oncology probably more than other specialties and internal medicine. The physical exam is definitely very much emphasized. And I would say that radiation oncologists are much better, do a much better physical exam by and large than medical oncologists. And that's because we have to aim, we're the aimers. Just like, what did Bush say? He was I don't know, whatever. I won't get into politics, but we have to hit our target. So, you can see a lot on scans, but you also have to know if it involves the skin or there's a rash, or so by and large, we're very good at physical exams. Um, Medical oncologists don't have to be as good because their drugs go everywhere. But if we miss our target, then our patient's not going to be cured. So, and that's not true of, I mean, medical oncologists are smart and good and hard workers, and by and large, much better all around physicians and radiation oncologists because they have an internal medicine background. They do 3 years of medicine before um, so I don't mean to diss medical oncologists at all. They work very hard and are very smart and are very good at what they do.
There you go. For the record, no hate to the medical oncologists. You know, we're not.
Absolutely. I give them
Yeah.
a whole lot of credit. They've
Yeah.
got busier schedules and sicker
Yeah.
patients, and they do more end of life care. We don't admit patients
Yeah.
to the hospital, they do. But the
Also,
one,
actually, oh, go ahead. Sorry.
no, that's it.
Okay. No, I wanted to ask about this, idea of hitting the target. Like number one, I kind of see, some parallels between your kind of interest in something surgical. Maybe it's not immediately obvious, but in both,
Yeah,
you're kind of like focusing on a very, targeted like location, and you got to identify that while avoid hitting the,
yeah,
non-affected structures. And so I kind of see that parallel. And then I was also going to ask, you mentioned that now the way you localize disease for radiation treatment is through imaging, and most of the time it's CT or MRI. And so, how are you doing that before? It's like hard for me to conceive of how that was
yeah.
possible if you didn't have the benefit of
I
of
know
those
it's
types of studies.
so crazy, isn't it?
Yeah.
Um, so when I was in medical school, we didn't have MRIs, and I'm not even, we were just getting CAT scans, I think. and I'm not 100, but I am in my
Yeah.
late 60s. But we would do it. So the way we would use plain films, and
Really? Wow.
we would use plain films. We would use the so the contours, physical contours of a person's body. We would have atlases, textbook atlases that would define where you would expect the nodes to be. So when we would set up, say, a Hodgkin's mantle field, which means Hodgkin's lymphoma, um, patients often had disease in the mediastinum or the neck or the axilla. Um, so some of it, if you felt lymphadenopathy, obviously you would include that in your target volume. But some of the lymph nodes you treated prophylactically, meaning where the cancer was, where there may be subclinical disease that you certainly couldn't see on a plain film and might not be able to see on a CAT scan. So you can have disease in nodes before that node changes in size or appearance. Um, we didn't have PET scans. So again, it was based, this is going to sound really archaic, but it's based on like autopsy data as in terms of the pattern of spread. One of the things you're taught is what is the typical pattern of spread of a malignancy. So Hodgkin's disease tended to have a very orderly pattern of spread. So if you had disease in the mediastinum, you were also at risk to have it in the neck, the axilla, and the lymph retroperitoneal nodes in the abdomen. And whether you saw them on a scan or not, and you use these atlases on plain x-rays to draw your field. Very archaic.
Wow.
Yep.
Wow.
But, and you would sort of transpose from like the plain film to it was, and for an example for how you treat breast cancer, um, you, we didn't scan the woman's chest or breast. You just laid them on the x-ray table. You took a wire and put it over their breasts and chest wall, a malleable wire, but thick enough to hold its um, shape. You then lift up the wire, bring it over to a drafting table, draw the contour of the breast and chest, and do all your calculations on the basis of the dimensions on.
Wow.
Yeah, pretty scary when you think about it. And then we
Well,
use,
I'm just in awe of the amount of resources and just the time it would take to kind of manually do all that for every patient.
yes,
That's,
and you really had to have a very, very firm grasp of normal anatomy as well as abnormal anatomy. But yeah, and it's amazing we cured as many people as we did, frankly. Uh,
hmm.
but so the way the technology has changed, and all the physics calculations were done by hand, you know. Um, yeah, with old-fashioned formulas. I had to do them myself. I had to calculate, I'd treat people in the middle of the night, their whole brain, and I would have to measure the distance from point A to point B and do all the calculate hands. Scary. But so now, thankfully, we use imaging to guide our uh, treatment planning and how we aim the beams, essentially. So we use CAT, CAT scan images, both axial, sagittal, and coronal imaging to define gross tumors that you can see, and then to define the lymph node regions or at-risk regions, even that are normal. So we sometimes treat not just the obvious disease, but again, where it's likely to spread. PET scan has revolutionized because that's functional imaging. So you might have a perfectly normal looking, retroperitoneal nodes on a CT scan, but they light up on PET. So you know they're involved with disease. So we now are able to, and we can fuse or overlay those images. So we usually start with a CAT scan, and then we can overlay the PET scan images as long as you are scanning them in the same position and are using fiducials to know that you're comparing apples to apples. But you can fuse the images, the MRI images with the CT images, the PET images with the CT images, to help you define the target area and the at-risk areas, which are part of the target, and minimize dose to the critical organs, kidneys, so you can design your beam energies, beam angles, number of beams, and there are computer algorithms that you put in the basic data, and the computer algorithm helps you to define that, to minimize, and then you actually calculate the dose to your target and calculate that you, as a radiation oncologist, define also all the normal structures that you're concerned about getting dose. And the dose to the normal structures is calculated as well. And so you try to optimize that with, again, this computer software that will help you to see, like, you might think, well, that's delivering the dose to the tumor very nicely, but I think I can minimize the dose to the liver. So let's try this, or and it's getting more and more sophisticated all the time. And I'm sure AI will dramatically change that too.
And can you speak a little bit about, how all these technological changes changed the personnel who are involved in delivering radiation treatment? I know you mentioned you were doing calculations for dosimetry, but at what point did dosimetrists or, medical physicists enter, collaborating
Yeah,
with the radiation oncologists?
that's a good question. Certainly there were always, as long, I mean, I would only calculate stuff in the middle of the night
Okay.
or weekends. So there were dosimetrists and physicists that I would work closely with during my residency, and subsequently.
Always there, and then as the technology changed, they were their roles kind of just translated into the technology, or did they take on any new responsibilities, or how did that
Um,
work?
we would all sort of have to be trained on the new equipment and on with the new technologies. And I always felt that sometimes that was harder for physicians to get that training. You had to seek it out. You had to, because things changed dramatically from when I trained to over the course of my career. So you really had to, continuing medical education was key. And the technology was key. There was a steep learning curve to um, using going from plain films and hand-drawn stuff to, computer-based imaging. So it was technically,
And things would advance that way. Like it's just hard. I'm still trying to wrap my head around that much change happened within your career. And
yeah,
so I don't
it's
know if anyone could have predicted that.
yeah, dramatic. And it was, you know, that was the hardest part, just learning the technology, and utilizing the technology, because there are no formal training programs for that. Um, you could go to meetings that would, well, that's not completely true. You could go to meetings where they would sit you at the computer and it was like a learning lab. You'd learn how to contour the normal structures and, optimize treatment plans and that kind of thing. But it was challenging, very challenging. And that's led to a lot more specialization too. Like head and neck anatomy, for example. When before we used CT imaging, you just looked at your textbook and your atlas, and it would define how you would draw your fields, where you weren't actually defining the tumor itself and the lymph nodes individually. It was just a much more, well, these are the fields that you treat for stage 3 larynx cancer. Um, with the newer technology and being able to see everything, you now had to, you yourself define all the at-risk structures and utilizing all of the technology to optimize things. And like just learning head and neck anatomy is like really, it's really intricate and really time consuming. But so that's why when you go to certainly academic centers, most radiation oncologists, they're only going to do like head and neck, or they're going to do prostate, or they're going to do GYN, or they're going to do breast. You can become most expert in the technology for that. Um, what was I was always a generalist, and that is, I mean, I would say I did a lot of breast cancer in my career because women like to see women. I was very knowledgeable and very skilled at it, and I found it very fascinating, and I found it one of the kind of most a very challenging disease to care for because it had so many aspects to it in that particularly depending on the age of the patient. So for instance, a premenopausal woman with high-risk breast cancer, you need to think about maintaining fertility in that woman. You need to think about maintaining bone density in that woman, when oftentimes the treatment um, takes away her hormonal function. So you got to be good at hormone replacement, monitoring bone density, a lot of anxiety and depression associated with it, understandably so. A lot of young women with young children they're trying to care for. Um, so you need to know how to support women. Genetics, it was one of the first diseases where we learned the specific mutations that were contributing to a subset of breast cancer patients. BRCA1 and BRCA2 were two of the first genes identified as specific cancer genes. So just very complex body image, plastic surgical options, just really complex managing the whole breast cancer patient. And I loved that. So, if you had to say what was your specialty, that I would say that was my specialty, but I was always in a very small practice, so I didn't have the luxury of just taking care of breast cancer. I treated everything. Um, and that's challenging. You had to be good at everything. Um, but it's interesting too. And it kept it, always interesting and always challenging. But I prided myself in most community hospitals. Um, the generalists are very good at pretty much all things, and for the most part, you don't have to send your patients. You needed to know when you needed to, when patients would get better care elsewhere. And they're either because they needed a clinical protocol, or for instance, brachytherapy, you need to be doing a lot of it to be really good at it, particularly GYN brachytherapy. So, you needed to understand when things were really beyond your level of experience. But that was pretty rare, to be honest with you. We were treating all diseases. We didn't do pediatrics, that's a whole other specialty, but yeah. So yeah, I mean, I feel like my career was, things changed a lot. It was always interesting, always fascinating. The part of my career that I think changed the most, well, certainly we talked about the radiation technology, but the whole cancer genetics really
Mm.
exploded during my tenure. So when I was at Yale doing my radiation oncology fellowship, in the mid 90s is when BRCA1 and BRCA2 were discovered by a woman named Mary Claire King. And that was part of my fascination with caring for breast cancer too, because to me, that was actually much more interesting, being the flea that I am. The genetics was more interesting to me than the physics, although that was fascinating too. But I really, really loved the genetics because I thought that now we're finally beginning to we're not reacting. I mean, radiation, although it's become so much more sophisticated and, the medical oncology drugs that we now have available to us are so much more sophisticated with monoclonal antibodies and small molecules and immunotherapy, et cetera. Radiation in particular is still a very crude tool in that you're still damaging normal tissue to a certain extent. You're still traversing normal tissue most of the time. And the way radiation works is it interferes with the DNA within the cell so that it doesn't kill the cell immediately. When that cell tries to replicate, you've damaged the DNA enough that that cell can't replicate. That's the simplified version. But we weren't involved in prevention at all, or early screening. So understanding, so cancer and all disease at its base is a genetic, abnormality. And with cancer, you they're not just acquired mutations, but inherited mutations. So I got very involved in, because BRCA1 and 2 were discovered during my fellowship, and because I took care of a lot of very young women where that was very important to understand that emerging science, because it's much higher percentage of the young women have the inherited mutations. Um, I trained in cancer genetics as well. So I didn't do a specific fellowship because I had already had about 25 years of training, but
You did your time for sure.
I did my time.
Yeah.
Um, but I did like go to a lot of conferences and get as much training as I could. And so I did an intensive course in cancer genetics in 2012 at an institution called the City of Hope, which was one of the leading cancer genetics research institutions. And it was let's see, it was a year-long course, most of it online, which was good because I still had a busy practice. But it culminated in uh, a week at the City of Hope, um, with an intensive review. And so I've stayed very involved in that community. I've gotten several certifications in genetics, and I have incorporated it into my practice. So I've been able to offer genetic counseling and testing well, I actually even did it prior to 2012, because I was involved with Myriad, which had the patent on BRCA1 and BRCA2. I was on their speaker bureau. I was on Ambry's speaker bureau. But anyway, so I've practiced genetics for probably 20 years. And as that's evolved, and that's just exploded. And particularly later in my career, that's been the most exciting and gratifying part of my career. I mean, I just am fascinated by genetics, and I'm unfortunately not practicing genetics right now, but I haven't given up on it. I want to, I still stay involved, but nobody's paying me. Um, but I want to, the problem is the need is great and the need will become greater because more and more now that we've sequenced the whole human genome, um, it's going to be a more and more important part of not just cancer, but cardiac and really everything. So there, it's easy to order the test. It's much harder to interpret it. And
Absolutely. Yeah.
there's a real shortage of people who are really skilled. But it's not well reimbursed and hospitals, are really operating on tight budgets. So unfortunately, there are long waits, 6, 8, 12-month waits for patients. And so I'm trying to finagle something. I might hang my own shingle because it's such a unique and important funded knowledge that I don't want to lose. And and it's continuing to change and be more and more relevant. So I'm hoping that I can, and I don't want to do a lot of it I mean, only because we care for our grandchildren 3 days a week. So
That's right.
that's my top priority. So I don't want to overextend myself, but I would like to try to maybe 1 day a week or a couple of days a month
Yeah.
do that. So
Are there any other changes just because I know we've been talking for a while and I don't want to keep anyone on this
sure.
call, beyond
Yeah.
their energy limits, but are there any other changes, whether from the technology standpoint or from the culture standpoint in medicine that you've noticed? I specifically wanted to ask you about, this idea of like the wellness thing and especially how it pertains to wellness of women who go into medicine who have historically been kind of minority, not really given the same opportunities as their male counterparts in a lot of ways. And so, there's this paradox, especially when you were talking about your training about how, as physicians, we're supposed to be people who promote health and help other people with their well-being and quality of life. Whereas, ironically, in order to deliver that, we're subjected to this kind of sometimes maybe unnecessarily rigorous or challenging training process where we're kind of taught to ignore our own kind of biological, emotional needs. And so, yeah, I was wondering if you could speak a little bit about how you've seen that change, just as a last topic. And if you think, I know you said, maybe it hasn't gotten a ton better, but yeah, what are
Yeah.
your general
Yeah.
thoughts on that?
So I think it's gotten a little bit better, but I still think we talk a good game and really we talk a good game, but really don't provide the opportunity, not the opportunities, but still the lifestyle of so many specialties is so bad that you don't have time to take care of yourself. So my choice to do radiation oncology allowed me to take much better care of myself and be a much more conscientious mother than if I was a medical oncologist or a primary care physician. Um, I feel like those would have eat me up and spit me out. From the standpoint that not that I wouldn't have been very good at it, but that the lifestyle I is so, you know, it doesn't allow for you to exercise every day or get enough sleep or spend enough time with your family. And when I was on call, and I was often on call a month at a time, but right there, that tells you something. Our call is really easy. We hardly ever get called, and we almost never have to go in. So that lends itself to being able to, and I could exercise when I was on call. I could, go to my daughter's softball game when I was on call. Whereas a lot of specialties, you're in the hospital, you're overnight, you're getting called all the time. So I do think there's more talk of it. There's more resources like sometimes institutions will offer, yoga classes or meditation um, or try to network with women in medicine, or there's a physician's, what is it called? Health resource or something for impaired physicians with, either drug or alcohol or, um, but I still think that it's why there's such a shortage in certain specialties because the lifestyle's bad, and often those are also specialties that are not very well reimbursed. So, um, you can't afford to have as much help at home or a nanny or whatever. So I still think, you know, in any woman with a, demanding career, not just medicine, and I think shout out to men. I think they're increasingly involved in the care of their children. And so men too struggle with this. But I still feel in most relationships, more is expected and more falls to the women in terms of childcare. Not all. I don't want to, I do think, you know,
Well, there are data to support that, like
yeah,
it's never like especially now where there's, in pretty much every family in order to make ends meet, you need both people working. And
yes,
so it's not like it's 50-50. It's, the
yeah, exactly.
you'll both go to work and then the childcare, household responsibilities, they are disproportionately allocated.
Yes. And I'm glad you said that. So it's not just my opinion. There is data to,
No, there are
yes.
data.
Yeah. So I just think, unfortunately, I think some of it's economic based, and it doesn't bode well with Medicare and Medicaid, Medicaid being cut and Medicare being threatened, and hospitals closing, and I personally think there's going to be a real crisis in healthcare. Not enough doctors, um, not certainly not enough primary care physicians. And I think the algorithm is going to have to change. I think we're going to have to, um, value and pay our primary care physicians better. I think we're going to have to give them, do change things so they have a better lifestyle so they can take care of themselves. My primary care physician is fantastic. She's a young woman, but she can't, she, and well, she does take care of herself, but it's like getting up at 4:30 in the morning to be on the treadmill, or, something's got to give. So I just think, um, that whether it's doctors unionizing or it becomes such a crisis that finally, we have to change the algorithms for what's paid for and how it's paid. Women are still paid less than men. One of my first jobs out of residency, I made $50,000 less than my counterparts, just same age, as much or more training because I was a woman. And I accepted what I was offered. So they sometimes say women aren't as good at negotiating, and there's probably truth to that. But they flat out lied to me and told me what the range was,
Mm.
gave me the upper. And so there was some change, like in Massachusetts now, there's the transparency, the
Yes, I think a
election.
lot of those things will
Yeah.
hopefully
And
help or have helped. Yeah.
I think that's important, But yeah, I worry about medicine. I really do. I love it. I would do it over in a heartbeat. I think it was perfectly well suited for me. And it was very gratifying, and I feel so good about I worked my tail off, but I helped a lot of people. And not a lot of people can, and I saved people. And I made people less frightened. And I, helped them through their journey, as corny as it sounds. But, I think for all of us, if you're ever on the other side of the table, which we all will be at some point in time, and you're frightened and vulnerable, you know, a caring, compassionate, knowledgeable, competent physician is, means the world to patients. And so, you know, I feel good about the fact that, I mean, I never had any desire to go to law school, but, there are people that are working gazillions of hours in law school. And not many of them can come home at the end of the day and say, you know what, I really helped this family, or I don't want to make a blanket, but, we work really hard, but we make really meaningful differences in people's lives. So
You know that, yeah, sorry, go ahead.
I'll go to my grave feeling good about that. And that's why I would do it over again.
I
But
think that
the but is, I don't think, I will add a but. I don't think you should be, you should have to sacrifice everything to be able to provide that care. I think that you should make a reasonable living because you have umpteen years of school. I have like 25 years of education. And I think not that that's the be all end all. More importantly, I think you should have a lifestyle where you can take care of yourself and your family as we preach to our patients. We should, and another example is like my daughter is a physician, and if Massachusetts didn't have its state laws for FMLA, she would have gotten like 4 weeks, maternity. And she also is a hospitalist, and some hospitalist jobs don't give any vacation. They say, oh, well, you get every other week off. Well, yeah, you're working 85-hour weeks. So, I don't want to get off on a rant again. I want to go back to feeling good about my career, but I just think you shouldn't have to give up everything to be able to provide really good care and have a gratifying career. Um,
I don't think that's a radical statement at all. It's just, it's not possible to give from an empty cup. So,
yeah,
um, I
it's
think
very
it just
true.
makes logical sense. And so, yeah, I think, you ended on a pretty perfect note, I think. But just to wrap up, my final question to you would be, unless there's anything else you want to cover from your end, but I just wanted to ask, if there are any young medical students who listen to this or undergraduates and they're interested in going into radiation oncology, do you have any advice for them? Or even, residents who are maybe in the process of training, what advice would you give to the next generation of radiation oncologists?
Um, that, it's an ever-changing, fascinating field. My own personal hope is that it's obsolete at some point, but I don't think that's going to be any time because I do think it's a very crude tool. I think the key is going to be understanding more about the genetics, again, both inherited and acquired, and knowing how to manipulate that, and understanding environmental and lifestyle factors that interact with those genetic changes, or cause some of those genetic changes. I think we're getting smarter, but it's going to take us a long time because it's not all genetics. There's definitely an environmental and lifestyle component, but for cancer specifically, but for most disease. Yes, so I do hope it's going to be obsolete and we have more sophisticated tools. I hope that we can prevent many more cancers, so that they won't need radiation oncologists. But assuming that's not the case for the next, I don't know, 50 to 75 years, I don't know. Um, I would say the technology is fascinating and certainly it's important to really understand the physics and the technology and the powerful tools that we're using and have a healthy respect for not just how effective they are, but the care that we have to take in delivering them, because there are certainly very significant risks as well. But also beyond that, I think it's a great specialty, again, because it's fascinating and changing. And I'm not embarrassed to say this, a good lifestyle, and I think particularly if you're a woman and want to have a family, I think it's a much better lifestyle than most. Um, the compensation is better than most. So it can allow you to work part-time and still have a reasonable compensation. And I'm not embarrassed to say those things either, even though that was not my primary motivation. Um, but I guess I would say, since it's such a highly technical field, really guard against and try to develop your hum humanity skills, there's still an art to medicine, and it's not just the technology. It's really, first and foremost, we are caregivers and healers. And I think honing those skills is equally, if not more important than knowledge of the technology. There, we need it all. So, but not to be so narrowly focused that you don't know how to talk to a patient, don't know how to examine a patient, don't know, how or when to hold a patient's hand, look a patient in the eye, give them the honest information that they need to make decisions as compassionately as you can. And I would also say, when you can, um, even though my conversation, use humor in your practice, both with your colleagues and your patients, once you've earned their trust and and be human with them, let them know a little bit about yourself, and make sure you understand about their person and who they are as a human being, not just as a diagnosis, because that's really meaningful too. And I'll end
I
there.
think that's a lot of outstanding advice, I think, not only for radiation oncology, but any specialty, I think.